Hello, everyone, and welcome to today's session, Meeting the Health Needs of Rural Elderly, making use of interactive data resources to improve health and target new services. Before we get started, I'd like to go over a few housekeeping items so you know how to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your GoToWebinar control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of your control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. If you have any technical issues, please type those into that same questions panel and I will address those ASAP. All right, I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. Welcome, John. You now have the floor.
Thanks so much, Sarah. And I'm delighted that so many of you have decided to join us today for this critical topic. Before we begin, we want to thank the John A. Hartford Foundation, whose continuing support allows us to provide this webinar free of charge to our audience. We also want to remind you that Grantmakers in Aging, through support from the Margaret A. Cargill Foundation, has a number of resources available on our website. If you go to our website and look for rural initiatives, you will find all of those listed there. Rural America is receiving renewed attention due to the great health disparities found there, and often those who fund programs and create policy do not know where or how to access the wealth of data that's already available. The NORC Walsh Center for Rural Health Analysis is a leader in documenting and highlighting rural disparities in health status and access to treatment services. Center staff will introduce participants to important data resources and highlight key rural aging data. We're very pleased to have with us two experts in the field. First, Michael Meat, who is the Senior Fellow in NORC's Public Health Department and is co-director of the Walsh Center for Rural Health Analysis. He's been involved for nearly 20 years in public health systems and rural health. Joining him is Alana Knudsen, who is the co-director of the NORC Walsh Center, and she also has been working for 2 decades and implementing and directing these areas, and she currently directs the Rural Health Tracking and Evaluation Project, a partnership with the University of Minnesota to examine the impact of rural health community programs funded under the Federal Office of Rural Health Policy. So welcome to you both. Before we get started though, I want to reiterate what Sarah had said at the beginning. We will be having a question and answer period later in the hour, but because there is a large number of attendees today, we are going to be doing that by you typing in the questions and me reading them to our presenters. You can go ahead and start doing that at any point during the presentation. So Michael and Alana, I will turn to you now and ask you to begin your presentation.
All right, well, thank you very much. We are very delighted to be speaking with you today. As John mentioned, we are from the Walsh Center for Rural Health Analysis. We are a nonprofit research organization in our 21st year of operation. It's something we're very proud of. We're located in the Washington, D.C. area so that we can connect to federal funders as well as philanthropy in trying to impact rural health policy. So what we want to do today, I'm going to start off and I'm going to share with you some national data. In particular, I want to highlight some work that we have done to try to document rural disparities at the national level. I'm then going to hand it over to Alana, and she's going to get a little bit more granular and share some additional data that also looks at rurality, but it gets down to the more regional level. And she's also going to talk through how the tools that we've been developed can be accessed and used. And then we're going to end with a discussion on some of the toolkits that we've developed. So in addition to trying to document what the challenges are, we always try to take a strengths and assets-based approach so that we like to look at what are the opportunities to leverage the different resources that are available to actually improve the health condition in our rural community. So we're going to end with some of that, and we will leave ample opportunity for questions. Let me see. I'm not getting it to work now. Yep, there it goes. So to get us started, this is actually work. This is not work that we've done here at the Walsh Center, but I think this is an important starting point. This is data showing life expectancy in both metro and non-metro areas, or urban and rural areas. This is a study that was done by researchers at the Health Resources and Services Administration within the federal government. What you will note here is that there's a growing disparity in life expectancy between urban and rural Americans. What's interesting about this is that if you follow this data to more recent data, what you will see is that we just experienced the first decline in life expectancy in the United States since 1993. What's notable about that is that in 1993, life expectancy declined as a result of the AIDS epidemic. Today, it's largely declining as a result of the opioid crisis. So we're starting to see that impact. But again, I think the main and very important point here is that there is this growing divide between urban and rural residents. So when we look at this, we always like to think about what we call the social determinants of health. We recognize as health researchers that the health community can only do so much in addressing the health disparities that exist. And in fact, when we look at the causal factors behind these health disparities, health is really only a minor part of that. So having access to doctors, having access to medical care is very important when you're sick. But if you actually want to influence the health of a community, also thinking about things like education, the neighborhood and built environment. Is it a safe place to live? Economic stability, probably the most important one of all. Do people have jobs? Is it an economically viable community? All of these sorts of things, at the end of the day, influence health as much as our health and healthcare systems. So what I want to do, and this is now going to take us into some of the research that we've done here at the Walsh Center. What I want to do is I want to share with you some of the high-level findings from a report we did. We did this a few years ago, but we based it on a report that the Centers for Disease Control and Prevention did back in 2001. We thought it was really important to update that data. It had not been updated since that time. We thought having a 10-year update would be important, but we also recognized that this would be the last opportunity to look at this data prior to the implementation of the Affordable Care Act, so that if we wanted to have baseline data so that we can see whether health reform was making a difference, we needed to update this data. To do this study, we worked very closely with the Centers for Disease Control and Prevention, and their staff were really gracious in working with us, table by table, graph by graph from their 2001 report, to make sure that we were doing all of the analyses as similar as possible to how they were done in 2001, so that we were comparing apples to apples. And I want to share really just a few of those findings with you, and then Alana's going to get into some the more granular detail with our mortality study. But this is really, I think, what's key here is that as you look at different levels of urbanization, so if you look at this chart, the A, B, C, D, and E at the bottom, these are our different urbanization categories, and the A, B, and C are all urban categories, from large central urban to small metropolitan areas, and the D and E are our non-metropolitan areas. These are both of our rural categories. Micropolitan can be thought of your small town rural communities, and non-core can be thought of as the more isolated rural communities. But what you see here is that as our communities get more rural, the population gets older. So this is the percentage of the population that is age 65 and older by level of rurality. And then this is another slide that essentially shows the same thing, but allows you to compare it back to the data that was in the CDC's 2001 report. That's the gray data, the gray line data, which was from 1998. And what's interesting here is that while the trend has been the same, that as communities become more rural, the population is older, while that's been true, it's more true today than it was 10 years ago. Our rural communities are older today proportionally than they were 10 years ago. And if you think about that a little bit, that has significant implications for all of the work that all of you do, but for communities in general, this has huge implications. If you are a community where your population is getting older, you need to make sure that you have services in place to care for that older population. The other piece of this that's really interesting is when you think about why these communities are getting older. So by and large, most of our rural communities are getting disproportionately older because many of the young people are leaving because there's not that economic opportunity. So as younger people leave, the average age gets older. What this means is not only is the average age getting older, but we have fewer younger people who can work in the different jobs to help take care of that aging population. So again, this has real significant implications for our rural communities. So this now starts to get into mortality data. So what is interesting here is that you see the same trend. As our communities get more rural, again, the micropolitan and non-core are two rural designations. As rurality increases, the mortality rates across all causes also increases. So what you see here is that our most rural communities have a rate of 600 people per 100,000 higher mortality than our most urban communities. That's 13% higher. And just for those of you interested, the top 5 causes that are attributable to this or that contribute to this are heart disease, cancer, chronic obstructive pulmonary disease, stroke, and Alzheimer's disease. When we look at this by region around the country, you see that this trend holds true throughout most of the country, with the exception of the Midwest, where things are a little bit more muted. But you do see vast regional differences. And again, Alana's going to get into some of those regional differences more. But even looking at all-cause mortality, you see that the South in particular has much higher burden, much higher rates than our other regions. And for many of our conditions, we see these trends in the South. So then this is probably not a surprise to most folks, but we also look at access to services. So this is a slide showing physician supply. And what we note here is that while the percentage of physicians per 100,000 has increased nationally over the last 10 years, that's not true for our most rural communities. Our most rural communities struggle with physician supply. And this is particularly true when you get into specialty physicians, which are virtually non-existent in most of our rural communities. Another major factor that we look at, because it is such a contributing factor to overall health and well-being, is total tooth loss or edentialism among individuals 65 years of age and older. We look at this by poverty level, and what you see here is, again, the trend that as our communities become more rural, they're more likely to experience total tooth loss. Individuals are more likely to experience total tooth loss. But the correlation between this total tooth loss and poverty is incredibly significant. This is much more likely to be true of people who live below 200% of the poverty line than for those individuals who live above 200% of the poverty line. And again, we see this trend throughout the country. This is looking at the 4 regions of the country. This is kind of not a very granular look when you only separate the country into 4 regions, but again, replicating the CDC report from 2001, looking at this in these 4 regions, you see this trend is really holding true throughout the country. And really, as with physician supply, we see the same issue here in terms of dentist supply. As our communities get more rural, the availability of dentists is much, much less. Very similar to our physician supply, there are more dentists today than there were 10 years ago overall, but not so in our rural communities where they experience the same shortages that they did 10 years ago. So with that, I'm going to hand it over to Alana, and again, she's going to get into our rural mortality study, which takes it to a more granular level. The study that I was showing, I mentioned we were only able to separate the country into 4 regions. The study that she's going to go through now, we were able to look at every one of the defined regions by the Department of Health and Human Services, as well as the Appalachian and Delta region.
Great. Well, thank you, Mike. The study that I'm going to share with you is a regional study where we specifically looked at mortality. And let me show you the areas in which we were looking. But first, I'll begin with the methods for this study. First of all, we looked at the National Vital Records data that the Centers for Disease Control and Prevention houses, and we grouped them in a similar manner as Mike explained in the chart book, where we looked at 3 different classifications for urban and 2 different classifications for rural. We then looked at the different regions across the country, looking at the Department of Health and Human Services regions, and we also looked at Appalachia and Delta. We conducted this study looking at different age groups, comparing infants and children with working adults, older adults, and then we also compared differences using gender, and through all of the ages and gender, we looked at the top 10 causes of death. And this slide depicts the regions of the country. So you can see where you are, and you can see what region you live. And one of the things that's very interesting about the research that we conducted looking at mortality is that we see a lot of differences in mortality across the country. And I'm going to share some of those findings with you. For example, this particular slide shows the top 10 causes of death for males in region 4, which is the Southeast. And this is for people 65 years and older. And so if you look at the left side, you will see it breaks out by age, sex, and region, and you can see the states that are part of that region. And then when you look on the right side, you see rural-urban status. And the green indicate those people that reside, or those mortality rates for people who reside in urban areas, and the darkest green is the most densely populated, or those very densely populated urban areas, where the lightest green is the smaller urban areas. And then when you look at the orange dots, those indicate our micropolitan, or the large rural areas, if you will, and non-core, which are our small rural areas. And when you look at this particular index, again, we're looking for the top 10 causes of death. You will see that there is a dark line that goes across at 100. That is the average mortality for our country. That is the average, if you will, across the country. So any of the dots that are above the line indicate a higher mortality than the average of the country, whereas any of the dots that fall below the line indicate a lower mortality rate for the country. And as you can see in this particular slide, the highest rate for males is in the lower respiratory diseases. People that are in the Southeast are the most likely to die of lower respiratory diseases, and that includes COPD, as Mike mentioned, as one of the top causes of death. The second leading cause, and again, this is for people who live in the most sparsely populated areas in these particular areas, is for nephritis, or diseases that are related to the kidneys. Then you contrast this with the females from that particular region. And what's interesting here is the top cause of death for females is also kidney-related, or nephritis. But then you see that there's also some challenges with septicemia. And again, when you look at the index, when you look at nephritis, or the kidney-related diseases, that means that it's over 50% higher than the average in the country. So there's something interesting going on. And one of the things that we know about that particular area of the country is that there are a lot of issues with hypertension, and then also you can see diabetes. But again, you can see that for people in these areas, women in these areas, you can see that almost every single orange dot is above the average. So people are more likely to die at a higher mortality rate than the rest of the country. Now we'll contrast this with Region 9, and this particular region is on the West Coast, including Arizona, California, Hawaii, and Nevada. And again, that dark line indicates the average cause of death, and any of the dots above that line indicate a higher mortality rate for that particular cause of death. And again, you can see for males in this region, lower respiratory disease was above the line, as are unintentional injuries. But I want to call your attention, they're not as high of a line as in the previous slide. And again, you can see that there are more dots below the line indicating lower mortality rates for people residing in the southwest part of the country dying from these particular causes of death. Now, when we look at females, I want to call your attention that the highest cause of death, and it's a 20% higher cause of death than the rest of the country, is for unintentional injuries. And just to give you an idea of what's included in unintentional injuries, it includes motor vehicle accidents as well as drug overdoses. And we know that different areas of our country, even for those that are 65 and older, are seeing higher drug overdose related deaths than other parts of the country. So we're keeping an eye definitely on how these different mortality rates are changing over time throughout the country. When you go to our site, and we have the website link on our last slide, you can actually create these tables yourself. So if you happen to be from Region 3 and you want to look at your own state or your own region, you can click and go to this website. It's very interactive, and you can click on the particular age group that you're interested in. And then you can also click on the gender and then the region, and you can get the top 10 causes of death. You can also do a deeper dive and look at just the single cause of death if you want to make a comparison, for example, looking at heart disease in your particular area and comparing it with the national level, particularly if you want to share that information, for example, with people that you are working with, or perhaps some of the potential people that you may be funding may be interested in that data. In addition, behind all of this data are all of the actual mortality rates. So you can look at an Excel spreadsheet and get a mortality rate for every single region and every single level of rurality, as well as statistical information. And if there's additional information that you would like us to provide, we can definitely do that as well. But recognizing our limited time, we just wanted to make sure that you were aware that there are tools available for you that are interactive and that can provide you some really good data regarding the mortality and the health issues that are impacting the people for whom you are interested in serving. This next section relates to some of the resources that we have. And as Mike mentioned, we have been working with the Federal Office of Rural Health Policy for the last several years to really help establish an evidence base of promising practices as well as evidence-based practices that really make a positive difference in rural communities. And through this work, we have been able to compile a number of different resources and practices and programs. And we use the Toolkit presentation modules to be able to really illustrate how rural communities can either adopt or adapt different approaches to addressing their locally identified needs. And these toolkits are all available on the Rural Health Information Gateway. Just to give you an orientation to our toolkits, we develop them in module fashion, and we include an overall introduction to each topic. For example, if we're looking at tobacco prevention, we provide some different models that have been implemented in rural communities, and these have been implemented successfully. Then we look at different types of implementation considerations, as well as some of the sustainability strategies, because as you folks know, oftentimes rural communities are able to get grant funding, and then they look to ways to be able to transition and maintaining those programs after their grant funding concludes. Then we also provide some tools to help them be able to evaluate, as well as different types of dissemination of what they are doing so they can share successes within their communities and among their stakeholders. And then we actually have a program clearinghouse where people who have implemented these programs successfully in rural communities can be directly contacted, because we know rural people like to talk to other rural people, and it's really helpful to be able to talk to people who have been there and done that, and have a real good perspective of what it means to get these programs successfully off the ground. This is an array of the toolkits that we have developed over the last 6 years. These toolkits now have had almost 1 million page views. Our rural communities use them. The Federal Office of Rural Health Policy also suggests that people that are communities that are interested in applying for grant funding go to these toolkits, because these toolkits have either promising practices or evidence-based approaches that are good to be replicated in programs that they are interested in accessing funding from the federal office and also from foundations. And this is the link that you can find these programs at the ruralhealthinformation.org. And as you can see, we cover a number of different health issues. And the Rural Community Health Toolkit is a general toolkit that also provides information for perhaps some topic-specific issues that have not been included yet in any of the toolkits that are currently available. Right now, we have a few toolkits that are going to be released this fall. One is transportation, and we are going to be sharing that at the October 18th meeting in Boston. We also are completing an aging in place as well as food security. And please know, Mike and I are always interested in new topics. The federal office usually funds 2 to 4 toolkits every year. So if you have some topics for future toolkits, please let us know. We definitely want to make sure that we are meeting the needs that our rural communities have, and working with their partners is very important in meeting those needs. And lastly, these are the resources that we shared today, the update of the chart book as well as the mortality differences. And you can find these resources available on these 2 websites. Again, the Walsh Center website has the chart book and the mortality information, and the Rural Health Information includes all of our toolkit information. So with that, we will open it up for questions.
Well, thank you so much, Michael and Alana. That was a very comprehensive but relatively brief presentation to give us a little hint about the tremendous resources that you have available. I do want to remind everyone that we will start with the question and answer process at this point, and you can type your questions in. A number of you already have. In the question box, you just open the panel that's there on the side of your screen and type in your questions, and I'll be asking those at this point. So let's start with the first one. We had several questions about methodology and availability of information. So could you say a little bit more about maybe some of the limitations of the data sources that you have available? So for example, can you do analysis down to the local town or county or census tract, or what are some of the limitations that people may encounter if they try to bring the scale down much further than the regions?
Yeah, so you are hitting on probably the most frustrating topic that we experience in rural health. The very nature of doing rural health research implies that you're looking at small population numbers, and because of that, much of the data is suppressed. When we gather the data from the Centers for Disease Control, they suppress small number so that no personally identifiable information can be released. And what that means is that you can't get down to the community level, which of course everyone in every community would like. That is a limitation. For our work, we replicated the CDC's 2001 report, which only allowed us to separate the country into 4 regions, which again is not very helpful. We were then able to get a little bit more granular with the mortality study and go down to the Department of Health and Human Service regions. Certainly state data is available, but once you start to get below the state level, a lot of that data becomes unreliable and ultimately is suppressed. There are some resources out there that model some of that local data, and that can be helpful, but always know that it's modeled data when you're doing that, because what it means is that they are looking at the demographics of your community and comparing it to other similar communities around the country and then pooling all of the data for those similar communities. It's useful in planning, but it may not at the end of the day reflect actual data from your own community. So always understand that limitation as well.
Lana, anything to add?
I would just add too that sometimes it's a little bit challenging too because data lags from a time standpoint. And so, you know, a lot of our interventions are maybe 2 or 3 years, and yet our data files are maybe not, they may lag 2 years. So you may finish a project, for example, in 2017, and our 2017 data will likely not be available till 2019. So, you know, that is also a limitation that you may want to consider when you're looking at using different data sources.
Let's stay with the methodology question for a second. Are non-federal resources also part of your information and studies?
Not for the chart book and mortality. These were all data sources that were primarily from the Centers for Disease Control and Prevention and other federal data sources. That's the most reliable data that we have that's consistently, collected and cleaned across the country.
Well, and I would also add that very much along the lines of what Alana was saying, the best data set we have is mortality data. It tends to be the most complete data set, although it has its own challenges at times. A lot of the other data that we have comes from national surveys. So it's things like what's called the Behavioral Risk Factor Surveillance Survey, which is a national survey to find out, you know, they ask questions about whether people smoke, what their dietary habits are, whether they exercise, things like that. And that's fine, but the sample sizes on those surveys are generally very small, and that's an additional type of data when you get into the surveys that you generally cannot take down to a very granular level.
Okay. I'll ask one more question about the survey information that you're able to provide for folks, and then move on to some other kinds of questions. And the question is about cost. I assume that the studies that you have published, that you have listed on your website, are all available for free. What if you wanted to do analysis that was specific to a region or area of the country? Is that something that you do as well, or is that outside of the purview of the center?
That is absolutely the kind of work that we do, and it's the kind of work that we love to do. The studies that we presented today were both funded through the federal government, so they are publicly available. That is really the charge of the federal agencies that funded the work. So we can, if anybody has any questions, wants to access any of that information, we are more than happy to try to direct you to everything that we've already done. If there are any more granular analyses, anything that the data can support, we have a team of really talented data analysts, and we would be happy to discuss that with anybody.
And I would add, too, we also have a group that we work with internally that they create some wonderful data visualizations. And one of the things that we have found is that oftentimes we get excited about spreadsheets with a lot of numbers, but a lot of other people don't. So if we can present data in map format or in different types of graphical format, that resonates the most with a broad spectrum of stakeholders.
And you know, just one more thing I would add. You may have other people in your regions, in your communities that can also do some of this work. And, you know, there's some very talented university-based people you should absolutely talk to. But as you reach out to people to do this kind of analysis, just be careful to make sure that they understand how to do rural analysis, because we often see rural analyses that are not done correctly. And I think that that can lead to its own challenges. And in particular, there are literally dozens of rural definitions that are used. So you want to make sure that people are applying the proper rural definitions for the kind of analysis that you want to do, and to allow comparisons to other data sets that you want to look at. So just make sure that you have people that are very capable and competent in doing that rural analysis.
Well, as you mentioned, most of the information that you have is from the CDC work on mortality, and obviously those are all related to medical conditions. What about some of the other areas that we know are critically important in terms of older people being able to live their lives with fulfillment in later life? Things like behavioral health issues, mental health issues. Are those included in any of the data sets that you work with?
Actually, they are. In fact, the CDC has added some additional components to what Mike was saying about the behavioral risk factor and surveillance survey. For example, asking components regarding activities of daily living, looking at any issues regarding dementia, looking at potentially if people have had or a family member has had a diagnosis of Alzheimer's. And Mike and I are also in the process of getting ready to release some questions that we have in our organization. We have a panel survey where we can also survey rural and urban people across the country. And one of the questions we have been really interested in is looking at preparations for long-term care and looking at how families are approaching that in preparing their resources and how they expect to pay for some of these incredible costs that we know lie ahead. And so we'll be releasing that study in the next 6 weeks.
Right. Let's turn to some other areas of interest, particularly one that's in the press almost constantly now in reference to rural areas, and that is the opioid epidemic or crisis that we are talking about a lot these days. There's a lot of discussion about it. Sometimes it's frustrating that there's not as much movement in terms of reaching out and addressing it. What are you looking at this point in terms of that issue, and what resources do you think might be useful for our audience?
So we have been doing some work looking at a group of conditions that are being referred to as diseases of despair, and you may have heard that terminology, but this is basically the combination of overdose death, suicide, and mortality from cirrhosis of the liver. So all of things that are appearing to happen, appear to be happening in communities where there is this economic divestment, this sense of despair. Of those, the opioid issue in and of itself tends to be the largest driver, but all of those things seem to go hand in hand. What we have seen nationally is that there are 3 real hotspots that have led the nation in terms of diseases of despair and opioids in general. That's New Hampshire, New Mexico, and Central Appalachia, Eastern Kentucky and West Virginia, and Southwestern Ohio. This has started to spread into other regions of the country so that they are not really leading the way they once were, which is bad news for the rest of the country. We are currently doing a study within the Appalachian region looking at the trends within Appalachia on how these conditions really appear to be moving. What we have found is that for every state that falls within the Appalachian region, the portion of the state within Appalachia has a much higher rate than the portion of the state outside of Appalachia, with one exception, which is Mississippi. But for the other states, that's true. And we have other colleagues who have done similar research more broadly around rural populations, not just within Appalachia, which show similar trends. What I will tell you is that what we are seeing is that the highest burden, mortality rate burden, is occurring in the 25 to 44 age range. So this is working age adults, but the rates are still high as you get into older adults. And there are a lot of additional related issues of grandparents becoming parents, opioid orphans, a lot of secondary issues that are occurring as a result as well. So this is really a primary issue that appears to be affecting many of our rural communities all over the country, and it's certainly something we're interested in and concerned about. The only thing I will add, the last thing I will add though, is I do have a concern that there is so much reporting on this that the perspective of urban America is that rural America is drug infested and is just this very bleak place. And we don't want to give that impression because our rural communities are still very vibrant, and this is still the minority of people and places that are experiencing this. So we don't want to overblow it and make it seem like this is the norm in rural communities either.
And I would add, as Mike had mentioned too, we are very committed to providing solutions to help rural communities. And one of our most recent toolkits looking at substance abuse has a number of real positive outcomes in some of our rural communities that have been effective in addressing their opioids. So again, using the toolkits on the Rural Health Information Hub Community Health Gateway site, that substance abuse toolkit has some really effective programs that can help rural communities address these really difficult issues.
Well, I will add that Grantmakers in Aging has also been involved in this area, and we are actually going to be releasing a report on August the 23rd addressing the particular needs of older people as it relates to the opioid crisis. As you say, the amount of reliable statistical data on many of the issues related to this is not strong. But I'll have to say, having now attended a lot of presentations on this issue, the discussion is almost entirely around addiction and treatment. It is almost never about issues like grandparents now raising their grandchildren, elder abuse, financial exploitation, the impact that it has on a community when suddenly you've got 10 times the number of deaths from drug overdoses that you had last year, any of those kinds of issues, all of which impact the elderly in a disproportionate kind of way.
And,
so
thank you. And I will, well, I will add to that. We did a study, again, in the Appalachian region back in 2008, where we were first able to document some of the opioid crisis. And at that point, so we're talking almost a decade ago, one of the things that we heard rural community after rural community in Appalachia was that older people were being used as the mechanism to get opioids, that it was easier for older people to go into a physician's office and get the prescriptions, and that this was seen as a social good within many of these communities because it was creating a source of income for some of the rural aging population. So this gets very complex at a lot of different levels.
Indeed it does. A couple more technically oriented questions. One is, are you working with any specific tools on well-being assessment? And the other one is, are you working with the 100 Million Healthier Lives, the Robert Wood Johnson funded initiative, and with their measurement team on any of these issues?
So we are doing a lot of work with the Robert Wood Johnson Foundation. They have been very generous in supporting some of our work to look at strengths and assets in rural communities, allowing us to really pivot from the disparities to try to look at what works and what is going well in our rural communities. Through that, we have connected to a number of different Robert Wood Johnson programs and initiatives. We have connected to their team that is trying to measure culture of health, their team that is developing the metrics to try to assess change in rural communities or in communities in general. So yeah, we are very connected with the foundation and trying to work with them on all of these sorts of things.
Alana, anything to add?
I was just going to say, with regard to the well-being question, this is something that we are really interested in. And as I mentioned, we have a particular panel here called the AmeriSpeak panel that has a representative group of rural participants. It's the only panel in the country that has that kind of membership in this panel. And so we are very much situated to be able to capture that kind of information in a very short amount of time. However, we just have not had funding at the federal level to really get to some of those well-being questions. I know some of the work that the Centers for Medicare and Medicaid Innovation has looked at that as part of some of their innovation work. But it is definitely an area where we are very interested, because we know that people's self-reported health status, for example, in many respects is more reliable than getting some of their biometrics. When people report that they have very good or excellent health, that's a much better indicator in many respects than people who, when you start correlating some of their biometrics.
And for those of you not familiar with panel surveys, this is an ongoing group of individuals who agree to participate in surveys on behalf of NORC, and it allows for very quick and low-cost surveying of individuals. This is a kind of a standard way of doing survey research. Ours is the most rigorous survey panel developed to date, and the only one, really, I think, because of our Walsh Center focus, really the only one that does allow you to collect data that is reliable at the rural community level.
Those are important resources. I was interested to see that you have a toolkit that you're preparing right now on aging in place. As you may know, many of our members have a strong interest in something similar, called by different names, livable communities or age-friendly communities. So could you tell us a little bit more about what that report is specifically trying to target?
Exactly. Well, as you know, we have such a high proportion of older adults living in our rural communities. And, you know, one of the things that's interesting in some of our work we have conducted for the last several years, most rural elderly would rather stay in their homes than go to some type of other living environment. And so what the Aging in Place really looks at are different models in which communities can address some of those issues. For example, we know that there are a lot of community-based types of options through our Medicaid program that many rural communities are taking advantage of to be able to support our elderly to remain in their homes. However, sometimes it's different to operationalize those in a more sparsely populated community. So, for example, this toolkit helps to address some of the barriers that often impact our rural elderly, such as how can we better support transportation? how can we ensure that people have access to services when they're at home and perhaps there aren't home health options? What might be some other tools or other options that we can use to help people remain in place? As you probably know, Mike and I have traveled the country, and we have had an opportunity to see a number of these interventions in play. And it's exciting to be taken to an elderly rural person's home who's 100 years old. And, this particular person that I'm thinking about, she was able to live in place because people were able to deliver her Meals on Wheels that were frozen because her ranch was 15 miles away from town. So she was able to get those kinds of supports even though they could not necessarily come to her home on a daily basis. So, there's a lot of innovation going on right now in our rural communities to help our elderly live safely and remain in their homes over time.
And when was that report going to be released?
This is actually going to be a toolkit, and that will be released this fall, likely in November.
Okay, great. I think there'll be a lot of interest in that. And as you mentioned, one of the issues that we often encounter, as I know you do, is that there's sometimes a tendency to look at rural communities and immediately jump to, despair, which unfortunately also means that particularly if you're investing in communities, it's not clear why or if investments in those communities will make a real difference. But we know it does. We know that there's very successful programs, and that's certainly a point of view that we want to continue to reinforce with everyone.
Yeah, I agree 100%, and I would even amplify that a little bit by saying that I do think that there is a barrier that many funders experience to making the investment in rural, and it's concerned that they're not going to be able to demonstrate impact or get good data to demonstrate outcomes. The flip side of that, though, is that our rural communities, there are not 10 different programs going on at the same time. So if you make that investment, you have a much greater likelihood of isolating the effects of your investment in a way that you can't do in larger communities. So I actually think that there are good rationale for making that investment and demonstrating impact and innovation in rural communities in a way that you couldn't do in a larger community. So I think there's some real compelling arguments for why it makes sense to invest in rural communities, and to know that when you make that investment, that there's actually in many ways a stronger likelihood that you're going to get good return on investment and demonstrate outcomes.
Well, we're reaching the end of our hour, but before we close our conversation today, I wanted to return to both of you to see what final comments you want to leave with our audience. Alana, let's start with you.
Great. Well, thank you so much for letting us share our work. And as we said, we very much welcome people asking questions, or if you need more information, please let us know. But I also want you to think about opportunities to partner with also some of our federal partners. We are evaluating a couple of different programs right now. One is a care coordination program that is a partnership between the Federal Office of Rural Health Policy and some foundations. One is the Empire Foundation in the state of Washington, and another is Benedin in Appalachia. And they have partnered with their local rural entity to be able to help support them in developing applications for this rural grant program, as well as to augment resources to be able to enhance the implementation and evaluation of the program. And what I think is a real opportunity is that this particular program has some great potential for sustainability. And with the partnership that the Federal Office of Rural Health Policy and the local funders have been able to create, these programs will be able to support the elderly in their community for years to come, because they have now created a mechanism by which they can get funding from the Centers for Medicare and Medicaid, as well as the commercial insurers, to provide this really important care coordination program for the elderly that they are serving. So I think about opportunities to work in a federal and foundation partnership, I think would be a great step forward.
Michael?
And I want to leave you on a positive note. So I am absolutely convinced that our rural communities around the country are very vibrant places. Alana and I travel frequently throughout the country, and even in the places that are experiencing really great challenges, there is a vibrancy, there is a commitment to improving community well-being. And I think there is a lot of innovation. One of the things that we hear frequently and see frequently is that in the absence of resources and investment, many of our rural community members have found ways to get things done, and they have done it in ways that are truly innovative because it's not by virtue of having a lot of money poured into their communities to solve the problems. So I actually think our rural communities are centers for innovation, and we need to systematically think about how we capture those stories and tell those stories so that we can translate and replicate that. And, you know, really at the end of the day, I think if we can help to communicate the positives of our rural communities in addition to the challenges, we got to acknowledge the challenges, but if we can highlight those positives, I think we can really help shine a light on what works and make sure that it's being replicated all over the country.
Great words to end our conversation today. I want to thank Michael Mead and Alana Knudsen for their participation in today's program. They're both with the NORC's Walsh Center for Rural Health Analysis, and you have their contact information there on the screen for you. We want to thank both of you for all that you do to make life better for older adults and the people of all ages. We also want to thank the John A. Hartford Foundation for their support of this program, and particularly in making it available to our wider audience. As I mentioned at the beginning, Grantmakers in Aging is providing a number of rural resources. If you go to our website, GIAGING or GIAging.org, and put in rural, it will bring up a variety of resources, and there'll be additional ones coming up soon. We will be making this presentation available to anyone who wishes to view it later, including both the slides and the audio. Watch for a rebroadcast link on our website or contact us at our website. And finally, I want to thank all of you for participating in today's webinar. Have a great day.